In this video, we demonstrate the replacement of a temporary bridge with a permanent one, following my proprietary clinical protocol. Special attention is given to the step-by-step intraoral bonding of sleeves, which ensures passive fit of the bridge, reduces stress on the implants, and facilitates intraoral manipulation. We remove the temporary bridge. The temporary polymer pins are removed. All unscrewing and rescrewing procedures follow a strictly defined sequence. We begin unscrewing from the distal screw and move toward the mesial one. The bridge is gradually released but remains secured on the mesial screw, eliminating excessive force and allowing full control during the procedure. Once the last mesial screw is removed, the bridge can be easily grasped and removed from the oral cavity. Screws are placed inside the sleeves. In this case, we are working with two sleeves. One of the sleeves is designated as the master sleeve. Its location is marked to avoid premature bonding. The master sleeve is always bonded last. The master sleeve is inserted into the most distal multi-unit abutment. Its purpose is to guide and secure accurate primary positioning of the bridge. We bond the sleeve. We take the sleeve with the screw already inside, hold it by the base, and apply the adhesive. The sleeve is inserted into the channel of the bridge. We remove the excess adhesive. The sleeve must be inserted horizontally into the channel of the bridge. This prevents the screw from falling out. We place the bridge onto the master sleeve, stabilize the bridge, and tighten the screw. This sequence enables the clinician to stabilize the bridge conveniently with unobstructed access to the screws. The tightening of the screw draws the sleeve toward the multi-unit abutment, and due to the cement gap between the sleeve and the crown, no stress occurs during this stage as the adhesive has not yet polymerized. The sleeve settles into the most accurate position, ensuring a passive fit, which is a critical factor in the structural integrity of the prosthesis. Polymerization is then performed. The bridge is removed to bond the master sleeve. The first sleeve is now fixed and serves as a guiding element for further steps. We unscrew the master sleeve. Following the same sequence of actions, we bond the second sleeve. As a result, we obtain a monolithic structure with two pre-bonded sleeves and integrated screws. The bridge is screwed back in and positioned intraorally. The pre-bonded sleeve ensures accurate and passive alignment. The bridge is secured beginning with the screw closest to the midline, as this provides better access, simplifies fixation, and prevents bridge slippage. Even fixed with one screw, the bridge remains stable. Therefore, fixation is always carried out from the mesial to the distal screw. Final polymerization is performed and occlusion is checked. Note the order of unscrewing, from the distal screw to the mesial one. The bridge is easily grasped and removed from the oral cavity. As a result, we obtain a one-piece structure with passive fit. Outside the oral cavity, we perform the following steps. We adjust the contact points, remove any excess luting material, smooth the edges of the structure, and thoroughly clean the surface. These extraoral procedures enhance workflow convenience and processing quality. The processed bridge is reseated for rechecking the occlusion. Adjustments are repeated if necessary. The bridge is placed for final cementation. Gingival pressure and fit are carefully evaluated. Then we proceed to the final stage. Screws are torqued and the screw holes are sealed with polymer pins. Adhesive is applied to the pins. Pins are inserted into the screw holes. Excess length is trimmed off. Polymerization and final polishing are completed. All these steps were performed strictly according to the protocol, resulting in a passive fit of the final structure. The sequence was designed to simplify the procedure as much as possible. Although first-time use may seem slightly confusing, after a few cases you will appreciate the convenience and clinical viability of this approach.